Hey guys, my name is Deanna Harris, and this is my 45-minute presentation for instructor methodology of the fall of 2025 class. My presentation is going to be on mental health emergencies and emergency services. By the end of the class, you'll be able to recognize some common presentations of mental health emergencies in the field, demonstrate an effective way to communicate and de-escalate situations in the field, learn some techniques of de-escalation and safe patient restraint techniques, learn some safe assessments and intervention strategies, understand the dual role of emergency responders, medical stabilization, and compassionate support, because we do have to do both. And then learn and change the stigma regarding mental health emergencies. That's a big thing with me. And we're going to discuss that a little more later in the presentation. So some introduction. 1 in 5 adults experience a mental health disorder annually. Not during their lifetime, but annually. So once a year, 1 in 5 adults experience a mental health disorder. And to me, that is a significant number. If you think about it, if you're in a class, and you have 1 of every 5 people stand up, 1 of those people annually will have a mental health disorder. EMS encounters are increasing in frequency and complexity. So on any given day, any kind of responder can be dispatched to any kind of abnormal behavior or mental health crisis. And it's not just an easy call now. They're very complex a lot of times, and it puts a strain on not only the patient, the responders, the mental health facilities sometimes are, they're overwhelmed by what's going on in the United States with mental health. And then stigma and the lack of training can affect patient outcomes. Absolutely, like I said earlier, stigma and the lack of training can affect patient outcomes, because unfortunately, a lot of people are labeled as just crazy, and that's not it. They have a problem, they have a mental health problem, and they need help. And what they don't need is somebody automatically judging them for something they have no control over. It's a mental health illness, and unfortunately, some people are judged because of it, and some responders do judge and label these patients as crazy and just dismiss them. And sometimes it does affect the patient outcome. And first and foremost, your safety is first. At the end of the day, you need to go home. It's your safety, my partner's safety, then the patient. We got to make sure that we're safe in everything that we do. Every call we go on, whether it be a lift assist, a code, a rec, any kind of call, our safety is always first. So, is there a difference in mental health and mental health illness? There is a difference. So, mental health, the definition of that is mental health encompasses an individual's cognitive, emotional, and behavioral functioning, as well as their ability to adapt to environmental demands and maintain fulfilling interpersonal relationships. And then mental illness will be a diagnosable conditions that affect mood, behavior, such as anxiety, depression, schizophrenia, and they oftentimes require support. So there is a difference between mental health and a mental illness. So there's some causes and risk factors: biological, genetics, brain chemistry, and chronic illnesses. Unfortunately, you have no control over that. Genetics, you have absolutely no control over, what you're going to inherit from generation to generation. So environmental, stressful life events, trauma, social discrimination, isolation, and substance use. A lot of mental health came about during COVID-19 when people were forced to stay in their homes and not socialize with anybody, and they weren't able to get out and do things. So there was an increase in mental health problems during that time. Psychological, so a negative thought patterns, poor coping mechanisms, personality traits, and some other factors that do um, affect like mental health would be lack of sleep, gender, socioeconomic status, and cultural factors. I know that you don't want to sit there and think that socioeconomic status would change a lot of things, but unfortunately it does. And some of these patients do have the mental health problems. So there's some signs of a mental health emergency in patients or in a partner, whatever it may be. Your partner at work, patients, bystanders, some things you can look for to say, hey, this person is having a mental health emergency. So obviously some threats or attempts to harm oneself, that homicidal, suicidal, if they're threatening it, it needs to be taken seriously because, a lot of people don't just do it for attention. Back in the day, everybody thought, oh, hey, they're just saying that for attention, but really they're not. They're actually looking for help. So anybody who threats or attempts to harm themselves or others needs to be taken seriously. That is a sign of a mental health emergency. Some delusions or hallucinations, sudden and severe changes in personality or mood. If somebody's usually happy all the time and next thing you know they're down and depressed, they're not smiling, that's a sudden and severe change in their personality or mood, and that could also signal a mental health emergency. Aggressive or violent behavior, unable to perform daily activities. They can't get out of bed, they can't feed themselves, they're not showering, they're not cleaning their house, maybe they don't show up for work, they just can't function at the daily activities that they normally would. And then drug or alcohol intoxication. So all of those situations that I discussed must be identified as they often require immediate intervention. Especially some of the threats or the attempts of hurting oneself or others, the illusions and hallucinations, aggressive or violent behavior, sudden severe changes in the personality, and the drug and alcohol intoxication, that alone could kill you, depending on what you're intoxicated from. Is it an opioid and, it's going to knock out your respiratory drive, they're not breathing, things like that. So some mental health illnesses or conditions that EMS responders respond to. So extreme agitation and violence, those are those ones, we're thinking about excited delirium. That's the one that everybody, when you think of mental health emergency, most everybody thinks of as excited delirium. But there's several others. Suicidal ideations, severe depression, co-occurring medical conditions, and we'll talk about that a little later. Post-traumatic stress disorder or PTSD, psychosis, some hallucinations, delusions, and or paranoia, anxiety and panic attacks. A lot of people have anxiety, and a lot of times, people are just ignored for having a panic attack. Like, oh, it's a little teenage girl. She just has some anxiety, but that is a mental health illness, and they need help. So, that we got to start changing that stigma. We can't keep looking at patients like they're just anxious or they're just crazy. That has to stop. Substance abuse induced crises, delirium, dementia, and then medication related emergencies. So some indications in the field that you may see: extreme agitation and violence, safety risks for both the patient and the EMS crews, and even bystanders, anybody around, family, anything like that. That extreme agitation and violence. The agitation can result from psychosis, substance abuse, and various underlying medical conditions. This includes excited delirium. So that's what I was saying earlier. When everybody thinks of a mental health crisis, they automatically go to like excited delirium because, that's what people have seen on TV. It's the people running down the streets, naked and just acting absolutely bizarre. And that's what everybody, you think of a mental health illness. And a lot of times you'll go to excited delirium. So verbal aggression, threatening behavior, some signs that you may see: clenched fists or jaws, pacing. These are the people that are just maybe climbing a telephone pole or standing on top of an ambulance naked or something like that, just acting absolutely erratic. And that is a 110% mental health and emergency, and they absolutely need help right then. So, suicidal ideations. This one is one of the most critical and frequently encountered behavioral emergencies. The common risk factors include mental illness, depression, painful losses, and substance abuse. So these people, threats or talk of suicide, hopelessness, they're hopeless. They start giving away possessions, and then previous self-harm attempts. Like I said earlier, a lot of times, people think that people do things for attention, such as cutting or taking pills or something like that. But a lot of times that's a warning sign that they are going to do something to themselves and harm themselves, possibly kill themselves later in the future. So some suicide facts, and this is pretty deep. In 2023, more than 49,300 people died by suicide in the United States alone, just in the United States. One death, and was very staggering to me. It was shocking. I was just like, oh my gosh, one death by suicide every 11 minutes. Every 11 minutes, there was one death by suicide in 2023. So, like, if you think about it, you go to dinner, and it takes maybe, an hour. So 5 to 6 people had committed suicide in 2023 in that time frame. So it's the second leading cause of death among individuals of age 10 to 34. 10 years old. Elementary school children. Have a godson that's 10. Unfortunately, a lot of that suicide comes from bullying and things like that, and a mental health disorder that is undiagnosed. The 11th leading cause of death overall. More than 90% of those who die by suicide struggled with mental health and or addiction. And 4 times higher with males than among females. If you look down in 2024, there are some other staggering, numbers. At 14.3 million adults had serious thoughts of suicide. 4.6 million made suicide plans, and 2.2 million actually attempted suicide. So, suicide is mental health as a whole. There's a lot of components to it. You have suicidal ideations, the excited delirium, but suicide, 1 in every 11 minutes. 1 in every 11 minutes. So some PTSD, some indications of PTSD. PTSD, the definition of that is just a condition that develops after experiencing or witnessing a traumatic event. Individuals who experience an acute crisis triggered by a traumatic memory or event. So flashbacks and some of the, the symptoms, they may have flashbacks, they may avoid, they may have feelings of guilt, exaggerated startled response, detachment and avoidance. PTSD can be in anybody under any, whatever may have happened to them. There are a lot of vets that have PTSD. There's a lot of emergency responders that have PTSD, but anybody can have it if they've experienced a traumatic event. And, they do try to avoid it. They have that survivor's guilt. And that's just something that completely continues to play in their brain. Like, why me? Why did I survive? Why did they not? And it just leads to problems. So anxiety and panic attacks. It's a response involving feelings or worry, fear, or unease, typically in anticipation of a future threat. Anxiety has become excessive, persistent, and significantly impair one's daily routine. So some signs and symptoms: tachycardia, restlessness, chest pain or discomfort, and shortness of breath. A lot of people have anxiety. I'll be the first to say, I have anxiety. I have to take medication for it. I've never really had what you would call a panic attack. My anxiety is I replay things over and over and over and over and over and over and over in my head, and I just can't stop. Like, it's a repetitive, just all the time. And, sometimes it would like impair my daily routine because that's all I was thinking about was just repeating what I was worried about over and over and over again. And, like I said, I'll be the first to say I have anxiety. I take medication for it, and it has done absolutely wonderful things for me. So, delirium is a temporary state of acute confusion and disorientation that develops rapidly. And dementia is a chronic and progressive decline in cognitive abilities such as memory, language, and reasoning. You know, some people with dementia do get violent, they are aggressive and things like that. But I want to more so hit on the delirium. So, some confusion, agitation, paranoia, sudden changes in awareness, altered mental status, loss of consciousness, flashbacks. Severe depression, also known as major depressive disorder or MDD. It is a common and debilitating mental health condition that can become an emergency. It can be influenced by genetics, brain chemistry imbalances, life events, and or medical conditions. They have hopelessness, severe sadness, lethargy, withdrawal, changes in appetite, not sleeping, things like that, severe depressive disorder. And a lot of times these patients do try to attempt suicide, and they're just helpless. I mean, hopeless. They just don't know how to get out. They don't know how to get out of where they are. So, co-occurring medical conditions, I talked about this earlier. I said we were going to hit on it a little bit more later on in the presentation. So it's one of the most important considerations for EMS providers is that a patient's behavioral symptoms may not be caused by an underlying medical issue, not a mental one. So you have hypoxia, stroke, hypoglycemia, head injuries, and they all can mimic a mental health crisis. So what you want to look for is your altered LOC, confusions, and changes in moods and behavior. A lot of those things we're able to fix other than the stroke, right? In the head injury, we can't fix that on scene, but we can recognize what it is and get the patients to the proper facility. Hypoxia, we can start giving some oxygen and maybe with increased oxygen they're not as confused anymore. Hypoglycemia, we all know, I'm pretty sure everybody in the class is in the medical field, but we have seen the hypoglycemic patients that you're just like, you're not making much sense. So it's important to get vital signs as soon as you can on these patients to try to rule out any H's and T's that we all heard about in PHCLS. Work out your H's and T's and figure out what's going on in an ACLS. So in psychosis, patients in a psychotic state may have disconnect from reality. Psychosis is associated with conditions like schizophrenia, bipolar disorder, and severe depression. So they have some hallucinations, delusions or paranoia, bizarre behavior, disorganized thoughts. On YouTube, I did not attach it to this PowerPoint, but on YouTube there is a video of a schizophrenic scenario that a lot of times they play in the CIT class. And what it is this male's, going through the day, and his loved one they're trying to call him on the phone and let him know that they ordered pizza and take the medicine and they were watching the news. Well, they began having hallucinations, and then the paranoia went into it. They thought the TV was talking to them, saying, they were worthless. The pizza that was delivered was poison. The coffee was poison. The medication they were going to take was poison. It's a really cool thing if you can find it on YouTube, or if you have maybe taken the CIT course, you know what I'm talking about. But if you have time, go to YouTube and look up the schizophrenic scenario, and it really puts some things into perspective. It would be so hard to function just daily if you were having like visual like hallucinations or auditory hallucinations, things like that. It's wild to me that, and unfortunately some people have to deal with that, and I hate it for them, but I think that the CIT course helped me realize that. So, plug here, if you have the opportunity to take a CIT course, please take it, but look up the schizophrenic scenario on YouTube and you should be able to find it. So, some substance abuse induced crises. Many behavioral emergency involve substance abuse and is the leading cause of psychological crisis. Patients may be intoxicated, in withdrawal, or have a substance related disorder exacerbating a mental health condition. So, they could have altered mental status, aggression, erratic behavior, tremors. In the county that I work, we actually have a PORT team. So it's a post-overdose response team, but they also help patients that are in withdrawal. So what they're able to do is they're able to get them in, to a facility for rehab. They start them on Suboxone. It's an amazing program. And hopefully that is helping some of the mental health problems that we have in the system that I work. But I'm not 100% sure where we are at with those statistics. So, some medication-related adverse reactions. So, patients with psychiatric conditions may experience an emergency related to their medications. And this could be an accidental or intentional overdose or a severe adverse reaction. I mean, at any point in time, you can develop a adverse reaction to a medication that you're taking, and you just never know. They're trying to be good, they're trying to take the medication, but they may have an adverse reaction to it. So they could have some altered mental status. They maybe have like unstable vital signs, muscle rigidity, the muscles roll hard, and then fever. So those are just some things you can look for. So what we need to do in our field is avoid tunnel vision. So you have your differential diagnosis. So some alcohol, acid-base disorders, arrhythmias, endocrine disorders, electrolyte disorders, some insulin issues. So you're diabetic, they could be hypo or hyperglycemic, opiates, overdose, uremia, which, your kidneys aren't expelling what needs to happen, and that can throw off your whole chemistry in your body, and it can cause altered mental status, or they can, maybe they're very agitated, they're pushing everybody away, they're trying to fight people. Your body does an amazing things in how it gets rid of the waste that we need, but if you have a problem there, it can cause problems elsewhere. Trauma, tumor, hypothermia, infection, intracerebral vascular disorders, poisoning, psychogenic, and then shock, fainting, seizures, and the mnemonic to remember some differential diagnosis when dealing with a mental health patient is AEIOU tips. So AEIOU tips. And that just helps us, not get tunnel vision and can't think of anything else. They're just they're having a mental health crisis. We got to do this, where it could just be, their blood sugar is 32. So try not to get tunnel vision. Try to take a full patient assessment. Use bystanders if you can. Look for medications. Look for anything you can to try to help you with your assessments. So some communication and de-escalation techniques. So it's important to treat everyone with kindness and respect, regardless of their mental health. Huge with that. Absolutely everybody should be treated very kindly and respectfully. And in this field, that goes a long way. You have got to have respect for people. Mental health conditions are common and can affect anyone. You need to be empathetic and don't judge or attach stigma towards those who may be struggling. Like I said earlier, the stigma around mental health is absolutely sickening. People are sat and judged and called crazy. They're just crazy. when they honestly have a problem and they need help and they just need somebody to be there for them that is not judging them. They just need somebody that's going to be there to help them, because some of these patients don't think anybody's going to help them, so they don't want help because people just judge them, and might as well do it on my own because then I'm not going to be judged. So you need to be calm and direct. Don't hesitate to talk to the patient about his or her condition. Use appropriate body language. So don't have your arms crossed like you don't care. Be relaxed. Show interest and openness while maintaining a safe position and distance. Avoid looking disinterested or using closed body language. Have a plan. Explain slowly and clearly what you're going to do, and never play into delusions. Don't agree with or further the patient's delusions. So if somebody says, "Oh, do you see that person looking in the window over there? You see them? Do you see them?" Don't play into that. No, I do not see them, but tell me what you're talking about. Let's talk about what you're seeing. Tell me what you're seeing. Be calm and direct. And we got to work on the stigma as a career, as a whole. Everybody's got to work on the stigma. So some de-escalation techniques verbally. Talk in a quiet demeanor. Don't yell at them. Don't be loud. Just talk in a quiet, calm demeanor. Just talk to them. Be straightforward and non-judgmental. Just be straightforward with them. Hey, right now you may be having a mental health emergency. I would like to check your vital signs. Can you talk to me about what's going on right now? Don't be judgmental. A patient can tell if just within the first probably minute if they're being judged by you. And that's part of the whole stigma. We've got to change that. Use the phrase like, "Let me see if I understand you correctly." If you say that to them, it shows them that you are actively listening to them and you do want to help them. You do want to try to help what's going on. You need to restate the patient's concerns and use open-ended questions. Some nonverbal de-escalation techniques that you can use are body language and posture, maintaining equal eye level, so don't, tower over them. Get on their level. We were taught this a long time ago in patient assessment. Get on their level. Don't tower over somebody and stare down at them. They're going to, that's going to get them up in arms. And if they're already aggressive, that's going to make them even more aggressive. Stay non-threatening. Like I said, don't tower over them. Don't yell at them. Don't bark orders. Don't have your arms crossed. Just watch your body language and your posture. Respect the patient's personal space. So don't corner the patient. Don't crowd the patient. Create some distance. If they're sitting on the couch and you come in, if there's a chair or something over the way, just squat beside it. But always, 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 and don't forget to leave an area for you to escape in case, the patient charges at you or whatever. You need to have an escape route in whatever you do because your safety comes first. So facial expressions, try not to have a judgmental facial expression. We do. Everybody has facial expressions, and people can read facial expressions from across the room. If they feel like you're being judged or you don't care, they're going to feed off of that. And it's just, maybe you didn't intentionally mean to make that face, but just try to work on your facial expressions. And practice active listening. That's another big thing. They just, they want somebody to listen to them. So some scene management and safety. So the lack of steadfast rules in caring for behavioral emergencies continues to be a challenge for EMS providers. Ensure safety during the scene size up and throughout the call. While not all behavioral emergency patients will be out to hurt themselves or you, caution is always warranted, because just like that, something can flip and they may want to hurt you or they may want to hurt themselves. So you always need to make sure that you're assessing the scene, everything during this, during the scene, it remains safe and things like that. So always seek law enforcement assistance early in the call. If you're advised to wait until the scene is secure by PD, wait. Whatever the call may be, wait. because your safety is first. At the end of the day, 110%, your safety always, always, always comes first. So until they say that the scene is safe, you do not go on scene. And just because they do deem the scene is safe doesn't mean it can't turn unsafe. So always have, always be aware of your surroundings, what's going on. Always have an exit way out of the house, out of wherever you're at to get to safety for you. Ensure you have appropriate PPE on, so body armor. So somebody who is suicidal or homicidal, in the agency I work at, any kind of calls like that, we have vests that we wear, and it says EMS on it, so hopefully they see it's EMS personnel. But you may need to wear something like that to ensure that you're safe while on the scene. So remain on high alert. Like I said earlier, always have an escape route, because at any point in time it can change. It can be very calm, collective, nothing's going on, and then in just a snap of a finger, something can change. And, you need to have a way out. Never place yourself in a corner. Have an escape plan, planned escape route. Pay attention to your partner. So you know how it goes. Your safety, your partner's safety, and then the patient. And your partner may see something that you don't see. Your partner may have another view that you don't see, or vice versa. So you need to always pay attention to your partner and be able to have that communication with them. So if something is going on, that you can communicate. And a lot of times we'll know our partners. Just by looking at our partners, we'll know, are they uneasy? Is something going on? We can tell. And just always pay attention to your partner. And have a plan or a safe word with your partner if you need to retreat. Back in the day, it would be, can you go grab me the purple bag off the truck? And they'd say, I don't remember where it is. Will you show me where it is? And then you would say, we're going to go get the purple bag. There's no purple bag on an ambulance. Well, not in the agencies I have ever worked for. Never been a purple bag. But if somebody said, hey, let's go get the purple bag, we knew something's going on. We need to get out of there. So a safe word, whatever it may be, bananas, whatever it is. Just at the beginning of the shift, talk to your partner about it. Like, hey, or even on the way to the call, hey, we're going to this call. But any call can turn into a mental health emergency. Remember that. So, I think we need to come up with a word. So just always have a safe word with your partner so you know when to get out. So crisis intervention teams, or CIT, are composed of highly trained emergency service providers who have received specialized training to respond to mental health crises, often in collaborative team with law enforcement or mental health professionals. And they're trained on how to effectively recognize and understand mental health emergencies, de-escalate situations, provide immediate medical care, connect individuals with appropriate mental health or social services, and have the ability to provide additional resources to prevent the patient from having to go to the hospital in order to receive the most appropriate care. Johnston Community College has an absolutely wonderful CIT program. I went through it. It's, to this day, one of the best classes I have been through. And I just say that if anybody has the opportunity to go to the CIT class, go to it. So it also talks about, they have, it can connect individuals to appropriate mental health. So there's facilities that we learn about that you can connect these patients to, where they don't have to go to the hospital. You can talk to them. Also in Johnston County, there's veteran CITs. So maybe a veteran's having a mental health emergency. We have veteran CIT trained people who are able to go to them. And just like I said, it gives you a lot of resources in your little toolbox that you can use on a scene of any kind of call. Any call. If anybody needs assistance, if they're not having a mental health emergency, but they have mental health problems and they just won't help, you have some resources. You learn about some resources that you can give to the patient, and they can, do what they need to do. So sometimes, unfortunately, there is a need for restraint. So unlike the police, who have broad powers in using reasonable force to detain a suspect, in the healthcare profession, we must remember, do no harm. So Sometimes police officers can get a little hands-on, but that's what they're able to do. We don't want to harm anybody. We don't want to injure anybody. So try your best to avoid patient restraint if at all possible. If at all possible, try to avoid patient restraint. Use those de-escalation techniques. Try to talk to them, see if you can get through to them that way. Safety is paramount, so your safety is first. Plan your approach. So if you do realize, we're going to have to restrain this patient, we have to. You need to plan it before you all rush in, okay? And we'll talk about that in a little bit, about when I said y'all, you have to talk about it. So you have strength in numbers. Restrain the patient supine. We've all seen the videos of somebody being restrained prone. That's an absolute no-no. Always supine. Keep the patient restrained and maintain your composure. Don't get all amped up, Maintain your composure. Take a deep breath if you need to. And if you have to restrain them for their safety or your safety, take a deep breath and then go do what you need to do. So continuous monitoring is paramount. So this includes checking the patient's airway, that pulses remain intact in all extremities, and that vitals are within normal limits. So always, 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 always reassess your patients whenever they're restrained. At least every 5 minutes, if not continuous. These patients really need to be restrained, because a lot of time that excited delirium patient, the straining and straining can lead to cardiac arrest. So we have got to always reassess our patients. I say continuously, but at the very minimum, every 5 minutes. So there's a difference between chemical restraints and physical restraints. A lot of times, if you do have to go physical restraints, you are going to also use chemical restraints. So you'll have both, where they're just relaxed, but they're not fighting the restraints anymore. Because like I said, you don't want people fighting that restraint. That puts a lot of strain on them. So benzodiazepines are used, such as Versed, Ativan, antipsychotics, Haldol, and then ketamine. Ketamine is a very big, drug that is used for mental health emergencies right now, especially excited delirium. But you have to be very careful with it, because if you by chance underdose your patient and don't give them enough ketamine, and I'm not saying overdose them, do not give them too much. You need to be actually right on the money with your dosage, because if you underdose them, you're going to make it even worse. They're going to get amped up even more. So physical restraints, soft restraints, or commercial restraint devices. And then you must have enough people to manage restraining a patient. So just you and your partner on a call, you cannot safely restrain a patient. You cannot do that. You can chemically restrain them, but you cannot physically restrain them. So you're going to need to have one person for each limb. You're going to need one person to distract the patient. You need to have a person at the head, and then a person that is able to tie it. So they say 5. At the very minimum, you need 5. In my opinion, at the very minimum, you need 6 or 7. But you're going to have all rescuers involved, because if they're fighting like that, you need to restrain them for their safety and your safety if the chemical restraints aren't happening. So here is a NCOEMS restraint checklist. So one of the very first things that you'll notice is the reason for restraint, and then you need to check all that apply. The patient attempting to hurt theirself. So not just threatening it, like if they're actively cutting themselves, okay? Patient attempting to hurt others, or patient attempting to remove medically necessary devices. So if a patient is being paced because they have some delirium, okay, and it's gone into, they have a low heart rate and you've got to pace them, But because of the delirium, they continue to try to rip off the pacer pads. Okay, this is where we're talking about they're attempting to remove some medical necessary equipment. So the heart rate, could be detrimental. So what we need to do is make sure that they're being paced. So we're going to need to restrain them, whether it be chemically and physically or just chemically. So your number 2 thing, you have attempted to verbally reassure or redirect. You attempted environmental modifications, removing the patient from the stressful environment. You have medical control approval. And then what type of restraint? And then always transport the patient in a position of the supine. And they also said here the lateral recumbent. And it also says vital signs should be taken every 15, like I said, almost continuous, if not every 5. So ending the stigma. Stigma remains a barrier to seeking help for mental health issues. Providers often encounter individuals who are reluctant to engage with care due to fear of judgment or misunderstanding. The stigma discourages people from getting help. They don't want to be judged. They just rather do it by themselves and they'll be fine. It creates shame and silence and judgmental attitudes that affect the care provided. So we've got to end the stigma and be open for these patients. They deserve the very best and we need to give them the very best. They do not need to be judged. They should feel like they can talk to us if they need to. So what you can do to help end the stigma, and I hope that you guys do try to help me in the stigma with this, is educate yourself and others, advocate for change, promote open conversations, treat them like a person. Don't treat them like they're crazy. Treat them like a person because that's what they are. They are a person. They are our patient and they matter. Show compassion and empathy and remind them that they're not alone. So not only do the patient's mental health matters, but yours does. So a lot of times we're just thought to, suck it up, you'll be fine. No, your mental health matters. And if you need help, you should feel like you can go get help where you need it. So it is important to take care of your own well-being. For example, getting enough sleep, eating nutritious food, exercising, and engaging in activities you enjoy. Self-care activities can positively impact your mental health, which in turn is going to impact your patient's care that they're receiving from you. Prioritizing your mental health can provide a strong foundation for your overall well-being and equip you with the necessary tools to effectively manage any challenges you may encounter. Healthy and coping strategies manage your emotions and stress. They can include sleep, breathing exercises, engaging in physical activities, talking to trusted adults, journaling, practicing mindfulness or relaxation techniques, or engaging in hobbies you enjoy. I enjoy playing video games. I told you that at the beginning of the class. That's what I'm going to continue doing. So in order to save others, we need to save ourselves. Okay? So let's go over some review questions. What is the difference between mental health and mental illness? What is the difference between mental health and mental illness? C. Mental illness is a diagnosable condition that affects mood, behavior, and thinking. Common types of mental health emergencies EMS providers encounter include suicidal or homicidal ideation, acute psychosis, severe anxiety or panic attacks, drug-induced behavioral crises, and severe depression. True or false? True. If you remember back about what we talked about, the mental health emergencies that we come in contact with are these. Why is the scene safety the top priority in a mental health emergency? Because patients experiencing a crisis may act unpredictably and or violently. Like I said earlier, at any point in time, something may change. So you got to make sure you're always safe. What is the medical condition that can mimic a mental health emergency? Seizures. A lot of times patients after seizures are posictal. They're completely confused, or maybe they're fighting you. They're scared, they're fighting. So it can mimic a mental health emergency. A patient with a history of schizophrenia is experiencing active hallucinations and is agitated. Which of the following is the most appropriate way to manage the situation? Approach the patient calmly and attempt to de escalate the situation. Try to calmly de escalate it before you have to do anything else, because remember, that's what we need to try to do. They're either trying to hurt themselves, hurt others, and the very next thing is try to de escalate that. When transporting a patient who has been physically restrained, what is the most critical reassessment? Reassess the patient's airway and breathing. There are other critical assessments you need to do, pulses. We need to make sure pulses are there and everything like that. But a lot of times these patients have received a sedative, so we need to make sure they're still breathing. End-tidal. Very important tool to use anytime you have a patient that you're sedating with chemically or anything. Really, I use it for any kind of call. So I hope you guys have enjoyed this lecture about mental health emergencies, and I do hope you help me try to change the stigma. Let's try to change people's minds that are judgmental towards these patients, and try to help them see that these patients just need help. Anyways, here's my references of what I used in order to make this slide, and I hope you guys have a wonderful day.